Good morning, everyone, and welcome to our first morning session on Friday, the second day of the conference. My name is Terri Klein, and I'm the President and CEO of the National MPS Society. And I'm excited to start off our session in care management with one of our very well-known cardiac doctors, Dr. Elizabeth Bruanlin, who's going to speak to you this morning. Dr. Bruanlin is a board-certified pediatric cardiologist and physician scientist at the University of Minnesota. She's been involved in the cardiac evaluation and follow-up of patients with MPS since the inception of the bone marrow transplantation programs for MPS disorders at the university over 40 years ago. I'd like to welcome Dr. Elizabeth Bruanlin.
Thank you, Terri, and thank you for inviting me to speak. It's great to be with all of you. This is the first run for this talk, so it may be a little bumpy, but I hope you'll enjoy it. Talking about cardiac surgery in adults with MPS, the big picture. I have no conflicts of interest. This is our goals for today: to describe the heart problems in MPS and how they are diagnosed, to define different treatment options. What are the factors to think about when undergoing heart surgery with MPS? And finally, formulate a plan to optimize the results of surgery. Well, first off, how do we diagnose cardiac problems in MPS? Usually we only do the first two things, which is history and physical exam and an echo and EKG. If we need further information, we may move on to a cardiac MRI or a heart catheterization to establish the cardiac diagnosis. So, what are the cardiac issues in adults with MPS? Well, I'm going to focus on three of them today. And one of them is cardiac valves. They can leak or they can become stenotic. I'm going to point on the screen to the mitral valve, and I am going to point to the mitral valve right here, which lets blood into the left ventricle, and the aortic valve, which lets blood out of the left ventricle. And those are the two valves that are primarily affected by GAG storage in MPS. You can have, as an adult, coronary artery disease. You can have traditional coronary artery disease where there's a blockage in your coronary artery. It's a localized blockage that causes the part beyond that blockage to not get enough blood flow. Or you can have MPS coronary artery disease, which is a diffuse disease, which is very hard to determine on coronary angiography. And we think, although we're not sure, that enzyme replacement therapy and bone marrow transplant both help with this MPS coronary artery disease. So the cardiac issues also include rhythm problems in MPS. And here's a nice normal EKG with a little hill before a big spike. That's electrical activity in the atrium and in the ventricle. So this is nice normal EKG. Sometimes you can have a heartbeat that's too fast, and this is a EKG from someone who's got a heart rate of 300. Sometimes not all of the signals from the collecting chamber, the little hill, can get through to the ventricle, the big spike, and that causes the heart rate to be very, very slow. Sometimes you can pass out with that. That's various degrees of what we call heart block. And sometimes the collecting chamber can just wiggle around and not have any organized beat, and that's called atrial fibrillation. You can see all of these things in adults with MPS. So echo, just like EKG told us about the rhythm, echo can find the cardiac valve problems. We can find valve regurgitation or valve stenosis by cardiac echo. And here's a picture of a left ventricle. And the echo probe is right here. And so that's where it's resting on your chest. And what you're seeing is the mitral valve, and over here is the aortic valve, and here is the pump itself. So blue flow is flow away from the transducer. This is blood flow going out the aorta. And red flow is blood flow coming towards the transducer. So this is blood flow coming across the mitral valve. And sparkly flow, like you see here, is turbulence. So what you're seeing here is there's turbulence at the mitral valve level, and it's going back into the left atrium or the collecting chamber. So this is mitral regurgitation. Over here, on the other hand, same mitral valve, but now you see the turbulence going into the ventricle. So that's mitral stenosis. And finally, here is a picture of the aortic valve with turbulence just beyond it. So that's a picture of aortic stenosis. There are published national guidelines that people follow that tell you how much severity there is for valve regurgitation or valve stenosis, and your cardiologist will know what those numbers are. And they'll also tell you what the indications are for cardiac surgery or cardiac intervention. So if the echo doesn't tell you exactly what you want to know, and it might not tell you the exact amount of mitral regurgitation or aortic regurgitation, for example, you can use cardiac MRI, and that can actually quantitate the amount of valve regurgitation. If you look at, and I do this every time, if you look at this picture of the left ventricle, you see the black here. That's regurgitation. The arrow is pointing to the regurgitation, and this black signal can actually be quantitated into a percentage of amount of blood that's going backwards into the left atrium. The other thing cardiac MRI can do is measure cardiac function or squeeze of the ventricle. And cardiac MRI can also look for scarring in the left ventricle or in the right ventricle as well. If we can't get the answers from that, and if we think that the problem is serious, we would probably recommend heart catheterization. And that measures pressures inside the heart through a catheter that's like a half-cooked piece of spaghetti. It has some body to it, but it bends and twists to go into the various chambers of the heart. And we can place that catheter in the heart, measure the pressures in the heart, and we can also take pictures through that catheter inside the heart. On the right-hand side, you see a picture of two tracings. The EKG is at top, and then below it is a pressure of the left ventricle. You can see it's about 120, and then the next line down at the 40 mark is a picture of the atrial pressure. And the green colored area tells you that there is some mitral stenosis here. And we can actually quantitate that and tell you how big the mitral valve opening is. So that's the final piece of the picture in cardiac diagnoses. We can take pictures of coronary arteries as well, and we can localize traditional coronary artery disease, which you can see right here where there's a nice big vessel here and here's the aorta, but there's only a thread connecting those two things. That's serious traditional coronary artery disease. For MPS coronary artery disease, they actually can put an echo probe, a tiny little echo probe into your coronary arteries, and they can measure the wall thickness. And people do that not only for MPS coronary artery disease and Fabry coronary artery disease, but also for heart transplant coronary artery disease. So all these things come together in a diagnosis. And let's say that the diagnosis is that you need to have an intervention. So what do we do next? Well, I'm going to talk about the treatment options primarily for valve stenosis because that's the biggest problem that folks with MPS have. The The top panel shows you that a balloon catheter can be put into the heart. The middle panel, you see the balloon being placed and you see a waist there. That balloon is across a narrow aortic valve, and the waist is made because the aortic valve is obstructive at that point. And they can blow up the balloon and relieve the aortic stenosis. You can do that for aortic valves, and you can do it for mitral valves. It's a very common procedure that's done in adults who have valvular heart disease. There are no reports that I could find in the literature of successfully doing that in people with MPS, and that's likely because the valves are different. They're quite a bit thicker and less frequently have a lot of calcium in them. So no reports for balloon dilation yet. Another thing that can be done in the heart cath lab is a transcatheter valve replacement. It's called a TAVI, transcatheter aortic valve insertion, or transcatheter aortic valve replacement when it's called TAVR. And that's done quite a bit in adults. It's done primarily in the aortic valve. There are some clinical trials now doing it in the mitral valve, but it's really done more commonly in the aortic valve. It's been done in several people with MPS successfully. The first time it was reported was nearly a decade ago in a young man who had an aortic TAVI performed successfully. And in this case, you put the catheter, you wrap a balloon, a valve, a mesh valve around the catheter so that the valve is all crimped and fits into the blood vessel. And then you deploy the catheter across the aortic valve. You blow up the balloon, and when you do that, the aortic valve, the new prosthetic aortic valve, expands. And there you have it. No chest surgery, no chest tubes, and likely you'll be able to go home within a day or two of the surgery of the cath. So the TAVI is used for aortic valve stenosis primarily. You can't use it for aortic valve regurgitation because the stent won't stay in place. And it's done on a experimental basis now for mitral valve stenosis or regurgitation. So what about cardiac valve surgery? Well, there's been a long, long history of successful valve replacements reported in all types of MPS. First reports were way back in 1980, well before enzyme replacement therapy was available, and just at the very beginning of bone marrow transplant. So these patients were all adults. They were all untreated by our current ways of treating patients, and most likely they all had attenuated MPS and were of near normal size. Well, that's not the world we live in today. So there are things that we need to think about for cardiac valve surgery today. So the first thing to think about is the choice of the valve. Do you want a mechanical valve or do you want a bioprosthetic or tissue valve? The next thing to think about is, what about all the other things that may be problems for me? What about my airways? What about my lungs? What about my spinal cord? What about my bones? What do I have? How do I key those into heart surgery? And finally, where in the world can I find a team that's experienced in cardiac surgery and in MPS? So let's take them one by one, the cardiac valve choices. Mechanical cardiac valve, shown here on the right in the open position above and in the closed position below, has been around for a very long time. This happens to be a low-profile valve. The good thing about mechanical valves is they're very long-lasting. Before they get approved by the FDA, they're on a little mechanical device that opens and closes them, and some of them opened and closed for as many times as you could live to be 100 years age. And so they're long lasting. They come in a variety of sizes, and they even come as small as 15 millimeters in diameter. Well, what am I talking about? I'm talking about the diameter of the mitral annulus, and the same can be said of the diameter of the aortic annulus. You got to get a valve that fits into the heart. And so having children who need mitral or aortic valve surgery has prompted the valve makers to make smaller and smaller valves that function. And that turns out to be a good thing for patients with MPS who are on the smaller side. Well, is there any con for a mechanical valve? Well, they can only be placed at surgery, and you need to have anticoagulation. So you need to be on a blood thinner. And that has the potential to complicate any future CNS or orthopedic procedures that you might have. So what about bioprosthetic or tissue valves? They are shown here on the right, and they can be placed at surgery or in the cath lab. The good news for them is that no anticoagulation is needed. Oftentimes, all you'll need is an aspirin. The cons are that they are fewer in size choices, going from 19 to 34 millimeters. And so smaller tissue valves are very difficult to find, if at all. And the other problem with tissue valves is they're not as long lasting as cardiac valves. Even in people without MPS, they become calcified, they become narrow, they become leaky within probably around 10 years' time. And so they need to be replaced. These days, some institutions can replace one transcatheter valve with another transcatheter valve, so you don't need surgery. But that's only in the aortic position. So they're less durable, and there actually has been a report from the Japanese literature about a patient who had a tissue valve placed and had to have it removed because there was gag deposition in the tissue. So that, I think, is a downside of a bioprosthetic valve. There are other MPS-related concerns, airways, for example. I'm not telling you anything new when I say that MPS airways are high-risk airways. Mouth and oftentimes doesn't open all the way. Trachea and bronchi can be affected with MPS. The landmarks that anesthesiologists usually look for when they put an endotracheal tube down somebody are often missing in patients with MPS. So what's a person to do in that situation? Well, intubation in MPS requires experience with MPS, and there are guidelines available that people can read, but this is not the place where you want someone to read a paper and then think that they know how to handle a patient with severe MPS. You need to ask for a preoperative assessment with the anesthesiologist. They need to understand the importance of maintaining neutral position when they intubate you so that they don't affect any problems with your cervical cord. They need to understand what has happened before. How did you have a successful anesthesia event? They need to have a plan. They need to have a backup plan. And then if you're undergoing surgery, they need to have a post-operative extubation plan. We've been very fortunate when things go very well in the operating room that the anesthesiologist will often take the ET tube out of the patient in the operating room, and they'll come back free of that ET tube. And that helps a lot because you don't need as much sedation. The ET tube is painful and annoying. You don't need as much sedation as you would if you had been kept intubated. And there are tricks that the anesthesiologist can use. For example, they can make your chest feel numb so you don't feel the pain of the incision. And there are lots of non-invasive ways of ventilating you postoperatively short of endotracheal tubes. The downside of this is you're going to be on your first postoperative night in the ICU with no endotracheal tube. If something goes sideways, you'll need to be re-intubated again, and that takes you back to all the risks of intubation. So it's not an easy choice to make, and it only occurs when things look absolutely perfect for intraoperative extubation. Other MPS-related problems relate to the cervical cord, and the arrow points to a spot in the cervical cord that has no white rim around it. That means it has no CSF surrounding it. It's tight right against the cervical cord housing. And so if you bend your neck or if you get placed on the operating room table in an unusual position, you can pinch that part of the cervical cord and you can end up with weakness or paralysis of your lower body or sometimes, unfortunately, of your whole body. So what's done for surgeries that are lengthy are to do neurophysiological monitoring during the surgery. We put little monitors on your hands and feet that report the electrical signals telling us that the nerves from your cervical cord are reaching your hands and your feet. We make sure that when you're positioned, the signal is as strong as it can be. And if during the course of the case, the signal decreases or goes away, the case is stopped and we figure out what is going on that is causing the problem. That may require repositioning on the table, or in some cases, it may require actually aborting the procedure before you get to the meat of it. In a paper that was written in orthopedic literature recently, about 20% of patients required some sort of injury during surgery to prevent injury to the spinal cord. Finally, there are orthopedic issues that Dr. White's going to tell us a lot about today, and that can include small rib cage, kyphoscoliosis, which can lead to decreased pulmonary function, and increased postoperative respiratory needs may be a problem if you have this situation. You can have joint pain and stiffness. Some folks are not ambulatory. You have to figure out how you're going to rehab postoperatively. For any cardiac intervention, experience matters. You can look at just standard coronary artery interventions, transcatheter valve replacements, and surgical valve replacements. The more you do, the better you get, or as they say, practice makes perfect. And here's a picture of surgical volume versus mortality. And you can see that the orange and blue lines become low between 100 and 200 cases of cardiac surgery done per year. So you need to have a center that is familiar with doing cardiac surgery. But MPS expertise also matters. Small stature is a big deal with MPS. You have problems with equipment needs. If you're going to an adult hospital, will they have the right size endotracheal tubes? Will they have the right size chest tubes? Will they know the ventilator settings? Will they know drug doses by weight? You need to have personnel expertise. Will the cardiac surgeon be uneasy operating on someone who is very small? These days, in some institutions, the pediatric cardiac surgeon, who is quite familiar with dealing with small people, will help the adult cardiac surgeon do a case or may even do the case himself. Team knowledge about MPS is very important. Knowledge about the airways and lungs, hearing and vision, about the central nervous system, about orthopedic issues, and about ongoing need for ERT during your hospitalization. So how can you formulate a plan? Well, I would suggest that you want to keep tabs on all of the things that are a problem for you now. You want to know the current status of your heart, your spinal cord, your lungs, and your bones. And it's an ongoing thing to know exactly how much affected each of those organ systems is. You'll establish a care team, and usually at our place, we see the geneticist, the cardiologist, the pulmonologist, the neurologist, and the orthopedist yearly. And we'll go through all of the potential landmines. So what if the cardiologist tells you, you don't need surgery this time, but in the next 3 to 5 years, you might need cardiac surgery? Well, what should you do at that point? I would suggest that that's the time to make sure the other organ systems are in tip-top shape. If, for example, you need to have an orthopedic procedure, do it while your cardiac problem is not critical. Same thing for cervical cord relief. You need to take care of that before you have a cardiac issue. And you should always optimize your pulmonary function, taking sleep studies when they're recommended to see if you need increased monitoring or increased non-invasive ventilatory support overnight, see if any meds would help. So with that information, you keep an ongoing tally of where things are for all the organ systems that are affected. Where can you get help once you have found out that you need cardiac surgery? Well, you can ask your cardiologist and your geneticist at home. You can search for centers with cardiac and MPS expertise. NORD has a website. NORD has recently made centers of excellence for 40 centers throughout the country that specialize in rare diseases. And there is a Center of Excellence registry that will tell you what center does what and who to contact. You can contact the MPS Society and ask them for any information. You can check advocacy groups, and you can also look at more perioperative management in adults with MPS from papers from Carolina Stepien, who's a cardiologist in Manchester, UK, where they have a large center that manages adult patients with MPS. So today, you've learned about the valve, coronary artery, and rhythm problems in MPS and how they're diagnosed. We've described interventional cath and operative approaches to treat cardiac valve problems. We've discussed the pros and cons of mechanical and bioprosthetic valves. We've discussed the specific airway, CNS, and orthopedic issues that are important when undergoing surgery. And we've worked to formulate a plan to optimize your current health and make an informed choice about a referral center. Thank you for your attention.